Cape Cod Broadcasting weaves the listening environments of 99.9 WQRC, Ocean 104.7, WFCC Classical 107.5, Cape Country 104, and CapeCon.com's website experience to reflect the lifestyles of the people who live, work, and play on Cape Cod. We hope that you enjoy this podcast.
I'm Laura Reckford, and this is Sunday Journal. I'm here in the studio with David Rehm, President and CEO of HopeHealth. David, welcome to the show.
Thank you. Happy to be here.
We're talking about the news that Medicare plans to reimburse doctors for conversations with patients about medical treatment at the end of life and how this represents a major change in public policy in health care. But, David, let's start with telling people about what HopeHealth is, because this is an organization that has had a name change in recent years.
Well, HopeHealth is a nonprofit healthcare organization. We provide an array of medical care, care management, and support services to people who experience serious illness or loss in eastern Massachusetts. People on the Cape know our organization as Hospice and Palliative Care of Cape Cod, which was our original name. But we did change several years ago because we have expanded our family of services. So it now includes Hope Hospice, Hope House Calls, which is primary-based care delivered to people in their homes, physicians with black bags, Hope Dementia and Alzheimer's Services, Hope Care for Kids, Hope Community Care, and Hope Academy, which provides professional and lay education and health care. And then in June 2014, the Massachusetts Pain Initiative affiliated with our organization, so they're now under our umbrella as well.
Lots of different things, and let's sort of zero in on hospice. Many people know what hospice is, but many people don't know. I'm always surprised when people tell me they don't know what hospice is. So give us an overview.
Well, hospice is a comprehensive program providing a team-based care for a patient and family facing a life-limiting illness. It has a complete array of services. Our teams are made up of nurses, social workers, chaplains, physicians, home health aides, therapists. We pay for all medications, all medical equipment, any transportations, any diagnostics, any treatments. So it's a comprehensive program for people at the end of life that it has been proven over and over again to be very successful, both in terms of high levels of patient and family satisfaction, positive patient outcomes, but also it turns out to be a cost-effective alternative as well. So it's one of the few win-win-wins in healthcare today.
I know it's a wonderful program because a member of my family went through it, but it's dealing with the family during a very traumatic time. And can you talk about the importance of families talking about death and end-of-life decisions and why it is so hard to do that?
Absolutely, I can. It is a critical need. By the time someone gets to hospice, we would hope that they've had an opportunity to have those conversations. Sometimes they come to us and they haven't, and so we can then help a patient and their family hold those discussions and take the time to sort out the questions and issues that are there. But our hope would be that families would have begun that process at an earlier point in time. We do see it more often because there's something unique about the way we do hospice. We call it our open door philosophy, and we admit patients, any patient who's eligible, at the earliest possible point. We don't wait until they've made a decision to forego treatment. So it doesn't matter how costly or complex a care plan is for a patient, as long as it's beneficial to them, we will go ahead and admit that patient and help them. So patients come to us earlier than they might normally in a traditional hospice. And so we do see patients and families early enough to begin some of those conversations. But really, what I always like to say to family members and to those of us who are prospective patients when we think about these issues is that by being willing to think about them, being willing to talk about them, being willing to engage in a process, and it's not a one-time discussion. It's not something you sit down in half an hour and sort out and make decisions with. It's something that a person and family have to work at for a while and takes time, and sometimes it takes professional help. But by doing it, you can avoid situations, and we've had some in the news in past years that have been really painful to patients and families, because we've ended up with family members with differing opinions about what their family member might have wanted, and they end up in legal struggles and so on. And I think by having those conversations in advance, when a person reaches the point where they're not able to make a decision for themselves, it enables the family members to act on their wishes. The other thing that's important in all of this is that I think we often think of this as something that we should do at the very end of life, but actually some of the most high-profile instances are people who were young and in good health, and there was an accident, or there was an incident, or there was an unanticipated healthcare event that left them unable to make decisions on their own, and so left families in some of these difficult situations. So that's one critical reason for it. The other, though, is that even if you're completely able to make these decisions, if you've prepared yourself, and you're ready and able to communicate with your attending physician or whomever you might be engaged in the healthcare system, it increases the likelihood that your wishes will be respected, that your wishes will become the base of the care plan going forward, and not, as sometimes happens, the preferences that get imposed by healthcare professionals based on their assumption of what you would want or what they would want. And so it's important to prepare yourself as well as your family.
And you're giving some great advice about talking about these issues when people are younger. When you bring it up at the end of someone's life, it can be a very difficult conversation. Your staff provided me with some background material on the issue, including a survey by the nonprofit The Conversation Project, that 90% of people polled thought it was important to have family end-of-life discussions, but only 30% have had them. So that actually did not surprise me at all. People know they should do this.
Exactly.
It's very awkward to bring it up.
Exactly. Even among healthcare professionals and even among end-of-life care healthcare professionals, we sometimes in meetings will ask people to raise their hands. And it's always striking how many there are in the room that actually have yet to follow through. So I think it's really something that I'm delighted this is getting the kind of public attention it is. I'm delighted that there is a shift in policy, because it's in the Conversations Project is one of those initiatives that's been ongoing around the country, trying to raise the visibility of the issue, trying to encourage people to think about it, to talk about it, to make some decisions and prepare themselves, because it's really can be a critical need met if it's anticipated.
And there, besides having the conversations with family members, there is this need to have these conversations with healthcare providers, doctors, family physicians. How does that work?
Well, up until now, it hasn't worked very well, honestly, because there have been two major roadblocks. There's been really no provision in our healthcare system to reimburse professionals to take the time with family members to hold these discussions. And unfortunately, when there isn't reimbursement, it doesn't get the attention that it might, and that's understandable, because healthcare organizations have to pay the bills and have to pay salaries and so on. So for the first time, Medicare in particular is now preparing to begin to pay healthcare professionals, and that's physicians, nurse practitioners, physician assistants, to hold these conversations with patients and families. So that's a big step forward, and we've had to overcome some interesting barriers over the last several years to get there. But now I think there's, particularly in Washington, there's a real understanding and support for this going forward. So I'm confident that this isn't going to go away anytime soon. The other piece, though, is one that I think will in some ways come after this, but it's training healthcare professionals to be able to hold these conversations. We have the medical technical information we have not always had, because it's not been part of professional healthcare training, particular experience in how to go about holding these conversations. So that's getting more visibility. There's a lot in the professional journals that's beginning to appear. Dr. Atul Gawande has been widely recognized and published. He's addressed this issue and started to bring attention to it in the profession, but also within the lay community. So I think we're starting to see a movement really gain some momentum here going forward.
I'm Laura Reckford, and this is Sunday Journal. I'm talking to David Rehm from HopeHealth about new rules from Medicare dealing with end-of-life issues. Now, with this new ruling coming down, what is the process here? Is there a public comment period, or how does this work?
There is. They have promulgated proposed new regulations, and there's a public comment period that runs through September 8th. That would allow anyone who would like to comment on this. And while I'm optimistic that it's going to go forward, I would absolutely encourage anyone who would like to go to the CMS website. It's not hard to navigate and find your way to the materials that would allow you to comment, because I think it's important that CMS and really. It's probably more important that Congress knows that people understand, want, and support this going forward. As you may remember, a number of years ago, there was a lot of controversy when this was initially introduced in the original Obamacare bill. Sarah Palin erroneously described it as a death panel, and people immediately became frightened of it and thought that it meant that somehow professionals were going to make these decisions for them. And of course, this is actually the exact opposite of that. This is really a healthcare professional giving you the information you need so that you can make your own decisions and ensure that they are in fact recognized and supported and followed. So that confusion delayed this whole process by a number of years. But now I'm part of a couple of different organizations that have been working on this and related issues in Washington for several years. Now I think it's pretty widely understood in Congress that was a mistake, that we're getting back to the right position. But I would encourage you not only to comment at CMS, but it's very easy to send an email or just pick up the telephone and call your congressman, call your senator, and just tell them that you're aware of this and you're supportive of it and would like to see it go forward. Not only would it help ensure this happens, but down the road it might help us expand this kind of support and service to patients and families.
Now, for our listeners who may be thinking they want to start this and have this conversation with their doctor, what are the specific things these conversations should cover?
Well, there are different approaches to it, but it's really sort of understanding the possible circumstances you could find yourself in, and what your preferences and wishes and desires would be, and so those are it's as I said, to really do it correctly, it's a fairly lengthy conversation. I don't think we've got the time to do the whole process here, but it really is should I have a serious illness? Should I be incapacitated? Should I be placed on life support? It's anticipating those sorts of things. What sort of choices would you prefer? And it's by getting that down and clear and understood and documenting it as well. You will just increase the likelihood that your preferences can be honored.
And as we all know, and you mentioned that these end-of-life issues can be political issues, do you think that there will be any other public policy changes happening around this issue of serious illnesses and end-of-life treatment?
Well, I think there's a growing awareness in Congress, and it's embedded in the ACA, the Obamacare bill, in a variety of ways. A growing awareness that people that are confronted with chronic illness, and most people over the age of 65, the majority, have multiple chronic conditions they're dealing with, that this is a population that needs more than our health system has been traditionally providing. They need coordinated care. They need managed care. They need supportive care. It's not since they're chronic and not curable conditions, it's really more about supporting their health status, managing their ability to function optimally, and so on. And our system has been so focused on cure that it has not provided the kind of coordinated management that these patients need. That's starting to happen. There's an organization that was formed in Washington called CTAC, which is the Committee to Advance Chronic Care, that's getting a lot of attention within the Beltway, that's trying to create a benefit that's built around these needs. That's just one initiative, but I think that we will see more discussion of this. I think we're going to begin to see that healthcare benefits for this population are going to be restructured, and I'm optimistic that when I need them, it'll be a different system than it is today.
In the last minute or so that we have left here, David, anything else messages you'd like to leave with listeners on this issue if people are thinking, I really want to find out more about this? Where can they go?
Well, they can call us at HopeHealth or get online and communicate with us through our website very easily. We have tools. We have one that we use called 5 Wishes that is widely known and widely used. We'd be happy to provide that to people. And then, I mentioned the different programs we've got. I talked about our hospice staff and how they can help, but in our house calls program, if someone's eligible for that program, and as long as they have a taxing effort that makes it difficult for them to get into a physician's office to receive primary care, they can be eligible. Our house call physicians and nurse practitioners can provide this kind of service and support. Also, we have a program called Specialized House Calls, which are licensed clinical social workers who go into people's homes and provide support to caregivers, and again, they can help with this. And then in our Hope Dementia program, we have a trained staff and a variety of different services available, and all of those can incorporate the kind of support. So I'd encourage you to reach out to us, because this is something I think we can help you with, but that in no way is discouraging you from having that conversation with your primary doctor, because that's your primary doctor for a reason, and that's the point that we want you to have that communication. We want them to understand your wishes, and we want you to develop it in conjunction with them.
Lots of great information that really applies to everyone. And unfortunately, we're out of time. I've been talking to David Rehm, President and CEO of HopeHealth. David, thank you so much for being here with me today.
My pleasure.
I'm Laura Reckford, and this is Sunday Journal.
This podcast is a presentation of Cape Cod Broadcasting, which is solely responsible for its content. Thank you for listening. For more information, please visit us at capecodbroadcasting.com.